Okay, so I don't have a person to practice on, so I'm just going to improvise a little bit, and I'm going to use my cardboard boxes. So the first thing I'm going to do is I'm going to knock on the patient's door, and I'm going to introduce myself. So I'm going to sanitize my hand. Come on. And then I'm going to close the door, provide some privacy, introduce myself to the patient. So hi, Mr. Smith. My name is Melissa. I'll be your student nurse today. So today I'm going to be doing a little bit of a respiratory assessment. I'm going to tell you a little bit about it and tell you how you can help me along the way. So the first thing I'm going to do is I'm going to ask you a bunch of questions, a little bit of an interview process, ask you about your history, your family history, lifestyles, medications, stuff like that. And then I'm going to have you expose your chest and your back. So just so you're aware, I did provide privacy, so you can feel more comfortable doing that. I'm also going to be palpating, which means I'm going to be feeling your chest and your back. And I'm also going to be doing some percussion, which is where I use my middle finger and then my other hand to tap. And I'm just going to be listening to the sounds throughout your lung fields. So I'm going to start off by asking you some questions about yourself. So what do you do? What is your history like? Do you have any history of pneumonia, asthma, cystic fibrosis, tuberculosis, bronchitis? Do you get colds a lot? Any type of lung cancer or any type of lung diseases? Okay, no, you don't have any. What about your family? What's your family history like? Do they have any past or history of or current issues with bronchitis, asthma, tuberculosis, cystic fibrosis? Do they get colds a lot? They have COPD, emphysema, stuff like that? No? Okay, that's good. What about your occupation? What do you do for work? Okay. Do you come into any contact with any fumes or chemicals? Any kind of paint? Sometimes those can affect your respiratory system? No. Do you have any allergies? Any allergies to pollen or dust? No. Okay. Do you live by a farm or do you live on a farm? No. Okay, so you have no contact with asbestos. What about your hobbies? Do any of those involve any kinds of toxins or chemicals that you may come in contact with? No. Okay. What about your travel history? Have you been to any bigger countries, bigger cities, states, like New York, China? Are you up to date on your vaccines? Okay. All right, everything sounds like it's good. What about your medication history? Are you on any corticosteroids, any supplemental oxygen, any inhalers, nebulizers, any narcotics, opioids, stuff like that? Do you take over-the-counter medications like Tylenol, ibuprofen? Okay, when you have a headache and stuff like that. Okay. What about any herbal supplements? Do you take any of those? No? What about usage of essential oils? Okay, you use essential oils every once in a while in your household. Okay. What about your lifestyle? Do you exercise regularly? Okay, 2 to 3 times a week for about an hour. That sounds good. Do you smoke or vape? No? Okay. Do you do anything else that might affect your respiratory system? No? Okay, that's good. Next, I'm just going to ask you a little bit about some signs and symptoms. Do you have any chest pain, throbbing headaches, shortness of breath on activity, any difficulty breathing, any air hunger, like where you're gasping for air? No? Okay, that's good. So as I'm looking at my patient and I'm asking him these questions, I'm looking at his nostrils and his nares, and I'm making sure that there's no nasal flaring. That could be indicative of difficulty breathing. Next, I'm making sure that he's not using any accessory muscles. I'm looking at his face, the color, and it all looks like there's no cyanosis, no pallor, so that's a good sign. It means that he's getting oxygenated fine. Next, I'm taking a look at his thorax. So I'm looking at his chest, and I'm making sure that it's not barreled. If it were barreled, then it would be like round here in the front, and it could be indicative of COPD. I'm taking a look at his nail beds and his capillary refill. I'm looking at the nail beds to make sure that there's no clubbing, and that's when the nail beds get kind of round here at the top, and they look a little different than normal ones. And that could mean that he's not getting enough oxygen to his tissues, which could also be from COPD as well. I'm looking at the way he breathes, making sure that he's not pursing his lips. That could mean typically COPD patients usually use pursed lip breathing. So I'm just making sure that none of that is present. Next, I'm assessing his respiratory rate, so I'll do that for a minute, and inspiratory and expiratory counts as one. The normal range for adults is 12 to 20, so his is at 16, which is normal. Next, I'll check his O2 saturation. I'll put it on his finger, and I'll make sure that his O2 saturation is 95 to 100. For a normal adult. For younger kids, it's 99 to 100, and then for patients with COPD, it's 88 to 100. So I'm just making sure that those are within normal ranges, and his is at 99, so that is very good. Next, I'm going to do some more inspection and some palpation. So I'm just going to move the camera a little bit over here. So what I'm doing here is I'm putting my hands on his chest, and I'm feeling for symmetrical chest movements. A lot of the times, if patients have a collapsed lung, the chest movements will be uneven. So I'm just making sure that they're symmetrical and that everything's intact. Next, I am going to feel the top of his shoulders, a little bit more on the chest and under his rib cage, and I'm looking for use of accessory muscles or retractions, making sure that he's having no difficulty breathing. The next thing I'm going to do is I'm going to look at the alignment of his thyroid and his trachea, and I'm making sure that it's symmetrical down the middle. When patients have a collapsed lung, it causes a mediastinal shift, and what that means is when the affected lung, all the pressure from the affected lung pushes the trachea to the opposite side, making it not symmetrical. So his is symmetrical, and that's good. Next, what I'm going to do is I assessed his rate, and his rhythm was regular, and the depth was regular. There's no signs of difficulty breathing, shallow breathing, or accessory muscles. Next, I'm going to place my hands here on the chest, and I'm going to have my patient say 99. And what this does is I'm checking his tactile fremitus. So I'm placing it on the chest, and he's saying 99. I'm moving down, he's saying 99, and then slightly under the rib cage, and he's saying 99. And like I said before, this is tactile fremitus, and I'm feeling for vibrations. If there was increased vibrations, that could mean that there's pneumonia. And then if there's decreased vibrations, it could be emphysema or COPD. Next, what I'm going to do is I'm going to listen throughout his lung sounds on the anterior chest. So what I'm doing here is I'm listening by the trachea, so in and out his mouth. And then after I listen to the anterior, I would have my patient lift his right arm up, and I would inspect here, here, and here. And what this does is this listens to the middle lobe, because there's 3 lobes in the right lung. After this, I'm going to do another assessment, but first I want to talk about some of the lung sounds. So when I listened up here by his throat, or like his trachea, those were bronchial sounds, and those are kind of short and loud. Then right here by his sternum, those were bronchiovesicular sounds, and those are kind of intermediate, so it's like a medium pitch. And then lastly down here by the nipple line, that was vesicular, and then right under his underarm, listening to the middle lobe, those were vesicular, and those are kind of softer sounds. Now that I assessed his tactile pharyngitis and his lung sounds while inhaling and exhaling, I'm going to listen again throughout the lung fields, except I'm going to have the patient say 99, and I'm going to listen with my stethoscope. And what this is bronchophony. So I'm listening to the patient say 99. So 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99. And when I'm assessing for bronchophony, I'm listening to the patient say 99, and what I should be hearing is the 99 sound muffled. And what that means is that it's normal. If I were to hear a clear 99 when I was assessing, then that would be indicative of fluid or air buildup, which could be due to pneumonia. Next, I'm going to do the same thing I did before, listen throughout the lung sounds, and this time I'm listening for egophony. So what I'm doing here is I'm having the patient say E, the letter E. So I'm going to listen throughout. So I have this patient say E, 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 and then E, E, and E. And as I said before, this is egophony, and when I'm listening with the stethoscope, I should keep hearing E. If I were to listen to a patient's lungs, and while they're saying E, and I'm listening to the stethoscope, and the E changes to an A, that would mean that there is swelling or hardening of the lung tissues, which is an abnormal sign, so I don't want to hear that. So I want to hear the E. And with my patient, I heard the E, so that is good. Next, I'm going to do some percussion. So I'm going to listen throughout the lung fields. Basically, what I'm doing is just to make sure that everything sounds normal. So I'm going to use my middle finger and then on my left hand, and then my middle finger on my right hand, and I'm going to push down and listen throughout the lung fields. So I'm going to go up here, up here, up here, up here, 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 and then I have the patient lift up his right arm, and I listen here, here, and here. There are plenty of different sounds that you can hear while doing this. Resonance is normal. It's indicative of a healthy lung, and that's kind of low-pitched and hollow. If I hear a dull sound, that would sound kind of muffled, and that usually happens when you're over a major organ. So if you're down here by the liver or up by the heart, you can hear the dull sound, and like I said, it sounds muffled. If I were to hear that somewhere where there wasn't an organ, that could be indicative of fluid buildup, so something like pneumonia. Next is flat. So flat sounds kind of like a soft thud, and what that could mean is that you're over bone or muscle tissue. And lastly, hyperresonance, that could mean that it sounds low-pitched but louder, and it's almost kind of musical. And what this could mean is that there's air buildup, so you don't want to hear any of that. So what I'm going to do next, now that I've finished assessing the anterior, I'm going to move on to the posterior and do the same thing. So I'm just going to shift my camera slightly over, and I'm going to go right here. Okay, so what I'm going to do now is I'm going to do the same thing I did on the anterior. I'm going to look at the patient's back, and I am going to make sure that everything is intact. The skin is intact. I'm going to put my hands down and look for excursion. So I'm putting my hands on the back, making sure that it's 1 to 2 centimeters apart, and I'm making sure that it's symmetrical on the back. So that's good. Next, I'm making sure that the skin is warm, dry, and intact, and there's no difficulty breathing. So next, I'm going to place my hands down the patient's back, and I'm going to have him say 99. And what this was, again, is the tactile fremitus, but on the back. So I'm putting my hands here, and I'm having the patient say 99, 99, and then put it slightly under the ribcage and have the patient say 99 again. Okay, and what I'm feeling for again is those vibrations. And then next, I'm going to do some listening to the lung sounds. So I'm going to have the patient breathe in and out of their mouth. So okay, and next I'm going to talk about those lung sounds a little bit too. So here by the scapulas, I heard bronchovesicular sounds, which is kind of like that medium pitch, a mixture of broncho and vesicular sounds. So it's not too high, not too low. It's kind of right in the middle. And then the vesicular sounds kind of a little bit softer throughout the lung fields here in the bottom. Next, I'm going to do bronchophony again on the back. So I'm going to have the patient say 99 again, and I'm going to listen throughout those lung sounds that I just listened to. And I'm listening for the muffled sound, because that is a normal sign. So 99, 99, 99, 99, 99, 99, 99, 99, 99, 99. Okay, and next I'm going to go over egophony, and that's when I have the patient say E again. And I want to hear the E. I don't want the E to turn into an A, because that is an abnormal sign as well that I discussed when I was doing the anterior chest. Okay? Okay, so I'll have to say E, 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 E. Okay? And then next, I'm going to talk about some of the lung sounds, the abnormal lung sounds that may be heard. So I'm going to start off with crackles. So crackles are usually heard at the base of the lungs. Those have like a popping sound, and it usually means excess fluid in the lungs. So we don't want that. That can be indicative of pneumonia or COPD. Next is rhonchi, which is kind of like crackles but louder. So those almost sound like snoring. And those can be with patients who have pneumonia, COPD, heart failure, and stuff like that. Next is a wheeze. A wheeze is kind of high-pitched. High-pitched and usually happens when you're exhaling, but it can happen when you're inhaling, and those are usually heard in patients who have COPD as well, or asthma. Next is a stridor, and it's a wheeze, but higher pitched, and those are typically heard up here in the upper airway. It means an upper airway issue. It could mean that the airway is narrowing or there's an obstruction. Next is a pleural rub. And the pleural rub is when there's not enough lubricant or surfactant in the pleura, so they start rubbing together, and that's like a scratching or a grating sound, and it can be really painful for the patient as well. And then lastly is absent or diminished lung sounds, and those are typically in patients who have a collapsed lung. When you listen to the affected side where the lung is collapsed, you can't hear anything because of all the air and like the fact that it's collapsed. And then the other side, you can hear breath sounds. So I think that's about it. I just want to make sure I did everything I discussed. Okay, I think that I covered everything here.